Good morning, everyone. Permit me to remove this. So I'll be sharing with us the little experience that we had gathered in Mainland Hospital since this outbreak started in February 2020. So this is the outline. I'll be talking about overview of Mainland Hospital Yaba. Manpower development for COVID-19 response, case definition of COVID-19, and then admission process, and then I will conclude. So the hospital, Mainland Hospital Yaba, was established in the 30s as a sanatorium or infectious disease hospital for the state. And I'm aware that there are 3 of such hospitals that were established in the country then. So basically, the hospital has been involved in the management of infectious diseases. The hospital has been involved in the management of infectious diseases, varying from tuberculosis, drug-resistant TB, to HIV, to cholera, to monkeypox, to Ebola, and now we have COVID with us. And the plan of the government is actually to make or to turn that center into a research institute and a center for disease control. So when Dr. Jide Idris was the Honorable Commissioner in Lagos State, the plan was drawn and some of it has been executed. Basically, the red area is where we have our highly infectious patients. But for now, I would tell us that every part of the hospital is actually highly infectious because all the wards have been converted into admission facility for COVID-19 patients. And ongoing in the hospital now, in the blue area. In the blue area is a 150 capacity isolation center being built by COVID, and hopefully that will be commissioned next week, and then we'll have many more patients going in there. The green area is where we have our BSL-3 laboratory, and that lab has been very useful in making diagnosis and in the containment activities ongoing. So when the first case came in February 26th, that was a Tuesday, we admitted him based on the history of fever that he had. He had fever for just 1 day, and then for the fact that he was coming from a region where there is an outbreak. He was coming from Italy at that period. The result came back the next day, and he was tested positive to COVID-19, and then other activities followed. So prior to his arrival, we had actually been preparing for a possible outbreak of COVID-19 in Lagos. There were several meetings with the Honorable Commissioner, and then we also had our own regular drills that we do with our staff, sensitization, so that people will be fully ready whenever we have a patient. Because we knew that the question would be when, not if. So when this patient came in, we admitted, and then the response was basically, let me call it indigenous. It was basically done by staff of Mainland Hospital, unlike 2014 when we didn't have any experience, and then it took us time to actually join in the containment activities then. So as of today, we have about 647 isolation beds in the state, and the various facilities hosting them are listed here. We have Mainland Hospital Yaba, we have LUT, we have Onikon Health Center, not health center, sorry, only consultation center. We have a landmark, and we have Lekki Isolation Center, first cardiology, and then Agidingi for health workers, and Bagada General Hospital. So today, a total of 647 beds, and hopefully another 150 beds will be added next week, as I mentioned earlier. What about manpower development? Because basically we knew that this outbreak is going to be a statewide outbreak. So Mainland Hospital alone will not be able to handle all the cases. So HSC with the IPC team and the case management team set up and started training volunteers. These volunteers are basically from our midst. They are doctors, nurses, attendants in the service of Lagos State government, and then other from the private sector. So series of trainings were conducted, and as of today, we have a large pool of trained manpower that can be deployed to work. And then, of course, the case definition for COVID. This has been modified several times because as the outbreak progresses, things change. Today, now we know that there is active community transmission of COVID in Lagos, and so the case definition is slightly different from when it was imported. Now it's been imported and it's resident with us. So far, we've admitted a total of about 1,232 patients that we've admitted, and then one was transferred from another state to Lagos. Luckily for us, he got well, and then we discharged him because he had multiple comorbidities, and he was afraid he wasn't going to do well where he was there. So this is the age distribution of our admissions. Let me go here. You will see that majority of our patients are actually very active people in their 30s, their 40s, and their 50s. In fact, the majority, 31%, is in their 30s. So COVID is not just a disease that affects the elderly. It's something that can affect anybody as long as you are exposed. As long as you are exposed, it can actually affect anybody. So these are the common symptoms that we've seen amongst our patients. Among the patients that were admitted into the hospital. Cough is the number one symptom that a lot of people present with, and that's about 14.4% of the patients present with cough. And then fever is also there, and then shortness of breath, chest pain, anosmia, that's loss of taste, general weakness. These are symptoms that can also mimic malaria. So whenever we have a patient presenting with this, we should always have in our mind the fact that it could be COVID-19 because of the active community transmission that we have. And luckily for us in Lagos, 68% of the patients are actually asymptomatic, meaning that they don't have symptoms at all. Should I say that is lucky for us? I don't think it's even lucky for, because these are the people that will transmit the infections to others unknowingly because they don't have any symptoms. So only about 32% will present with any of the symptoms that are mentioned to us above. So this 68%, the plan is that we will stop admitting them, and then they can take their treatments in the community, because we are beginning to see now a lot of people coming down with moderate to severe infections or disease process, and then they need bed space. So we need to ensure that bed space is available and then access to treatment. So this is the severity, as I mentioned. Most have no symptoms, about 68%, and then about 29% have moderate symptoms. They have fever, they have cough, they have the symptoms that I mentioned, and then about 2% come in breathless. They come in breathless and they have hypoxia with very low SpO2. SpO2 above 90, but way lower than 95%. And then these ones will require oxygen and prompt treatment, or else they will become critical, and then they may need ICU service, and mortality will definitely be higher once they become critical and then have to go to ICU. So, because a lot of people don't have symptoms, and really, that may be the reason why people think that COVID is actually not real, because they don't have symptoms, they feel well, they carry the virus around, and so to them, COVID really does not happen. But for those that have severe disease and the critical ones, it's actually a battle for their life. So this is the proportion of our admissions with comorbidities. About 24% have comorbidities, and I will show us what the comorbidities are. The commonest one that we see, and then the ones associated with fatality. So majority, 76%, have no comorbidity, no hypertension, no diabetes, and other comorbidities that's associated with high mortality. And then duration of admission overall is about 12.5 days. Most of our patients will have converted by that period, and then will have gone home in about 12 days. And then this is the graph of our discharge. We discharged a total of 866 patients so far, and it also reflects in the age distribution, as I said about the admission. So when our first patient came in February, we didn't have any regimen, but we had access to the WHO guideline. And the first drug there is remdesivir, which we didn't have at all. I got a contact, we sent mails around, and the mail went around, so several people, but eventually we were not able to have access to remdesivir. So we thought, what other medication is on that list? The number 2 medication on that list is Lopinavir, Ritonavir, which is our Alluvia here. And that is actually abundant in our pharmacy because it's one of the medications that we use for the treatment of our HIV patients. So the drug was readily available. The side effects are minimal. The drug is tolerable. So we decided to adopt that, the Lopinavir, Ritonavir, as our base antiviral agent. And then we added some antibiotics, vitamin C to boost the immunity, calcium because of the diarrhea associated with Alluvia, Lopinavir, Ritonavir, zinc, and then now some patients are also giving convalescent plasma, since we have a lot of people who have recovered and are willingly donating plasma for our use. So basically, this is what we started with, and chloroquine and hydroxychloroquine, we didn't have access to that at that period, so we never considered it. But in my own experience, I have seen 2 patients who were placed on that, and eventually we had to discontinue it and commence them on the Lopinavir, Ritonavir regimen, and they improved drastically. So this is our deaths. Most of our deaths actually have happened in male. Male happens to be the largest group of patients that are actually admitted. It's about a ratio of 7 to 3. Why it affects most men? Well, the last time we had the seminar here, it was said that it could be due to the fact that men have more receptor that the virus is attached to. We also noticed that most of the severity actually happen in the male sex. For the female, quite a number of them are asymptomatic, and or they have very mild symptoms. So that is the death that we've seen is more in male. And then, of course, that could also be because we have more male admission than female. And then The deaths occur more in people from the age of 50, between age of 50 and 69, because they made up for about 62% of our deaths. We still have death in the younger population. We had a 19-year-old that died. So yes, we had a 19-year-old that died, and but basically is those between 50 and 69. And then 58% of the deaths occurred in people with comorbidities. And then I will mention what those comorbidities are later as we go on. And those without comorbidities made up 42% of the deaths. So the commonest comorbidity leading to death is actually hypertension. And then a combination of hypertension plus diabetes tip the scale more towards mortality for the patient. So hypertension is one, diabetes is also there, but the combination of the two is actually very lethal to anybody with COVID. So, in conclusion, are we getting to a new normal? That is the question that we've asked ourselves several times. Are we getting to a stage where anybody appearing in our hospital is a potential COVID patient? And how do we go about handling them? It's a question that we all need to answer. And then what is our role as general hospital in management of these patients? Especially what is the role of the tertiary institutions, LASUT, LUT? They are supposed to lead the fight, and then the science too of COVID. So what happens to other patients with other conditions? Patients who have eclampsia, patients who have CVA, those that have cancer, what happens to them? Do we refer all of them to Mainland Hospital, or do we use appropriate PPE and then attend to our patient and then run the test if we think that the patient has COVID? I'm sure that by the time we have a certified rapid test kit that is available, it will be easier for us to actually do the test and then probably do it for everybody that comes. And then that will give more confidence to the health worker to actually treat their patient if they have a negative test, rather than not knowing whether the patient is positive or not, and then the fear of infection. So for those that also have co-infections, people with HIV, people with TB, where do they go to assess their treatment? Because for now, our patients who are TB patients are no longer coming to our hospital. One, because some of them may say that is where they treat COVID, and then two, because we're also actually treating COVID. Where do they go to? Who will manage them for us? Thank you very much.
Bowale, thank you very much for that. I'm sure there are going to be lots of questions, but I think because you are here, I think it's easier for you to sit here. There are some people, so you're not standing all the time. Dr. Bowale has asked some pertinent questions for us also to answer. So any questions in the house? Okay. Questions in the house? I knew it. Dr. Bowale, you're in trouble. Yeah, okay. And then, before we take that, I think there's one question on the line. So let me ask that before all of you start asking. Where is that question? Dr. Bowale, do you put every patient admitted on medication?
Yes, we do. Once you are positive for COVID and you come in for admission, we start you on medication, everybody.
Okay.
Thank you, Dr. Bowale, for that presentation. And I want to seize this opportunity to salute your courage. My facility is peculiar because the MCC is about 1 kilometer away from the main hospital. And I discovered that virtually all the COVID positive cases came from the main hospital. Did you see any pregnant women in your own experience? And then secondly, because most are asymptomatic, we're doing the basic electro, assuming that everybody that passes us by is a COVID positive case until proven otherwise. But we're having issues because of structure of our facility. And we don't know whether you have any suggestions for us. You asked many pertinent questions, and I'm throwing this one back at you. For those of us who are managing asymptomatic, and they're coming in volumes, we have space-limited structures. What do you suggest, sir?
Thank you very much. Thank you very much. You've seen quite a number of patients who are pregnant and also have COVID. And in the news recently, a few of them have been delivered of their pregnancies, and the baby and the mother are actually healthy. One of the earliest patients that we had happens to be 6 weeks old, who had gone to deliver somewhere outside the country. And then, of course, the mother and the child came back with COVID. So we've seen quite a number of pregnant women who have COVID. And then, as per what do you do for your facility, or how do you go about ensuring that your staff don't get infected? I think number one thing is to actually use appropriate PPE, which is very important. Social distancing is also very important, even in the hospital. Your consulting room should be such that patients are some distance from you. But of course, if you need to examine, you need to put on the appropriate PPE, which may not be more than maybe face shield, your face mask, and then gloves to actually attend to that patient. And then where things are going to be more than that, you may have to use a disposable apron. But really, you don't need more than that to be able to attend to your patient and run your clinic efficiently. And then you can also do staggered appointments so that patients don't cluster at the same time in your facility, thereby encouraging spread of infection. Thank you.
I have a question. Dr. Bowale, this is a question. I appreciate your presentation and the great work that you're doing. My question, I'm worried about late release of results. In my center, we are still expecting results of our staff done on the 22nd and 23rd and 26th of April, and also 14th of May. Can you throw some light on this?
Late release of result has been a recurring issue. And I know that a lot of the MDs have complained about that. I think the lab is working as best as it can to ensure that results are released as early as possible. Where you have staff that where you have staff that are going to undergo where you have staff that needs to have tests done, it may be important for you to actually inform the director of the biobank so that they can prioritize. But the issue is that it's still the same lab that run all the tests from the community, and they work 24/7. They work 24/7. So things now become better when we have the validated rapid test kit, which you can also use in your establishment to run this test. But for now, there's little that we can do than to continue to encourage them to release the result on time. And I think that is it. And then one advice I've also given. One advice I've also given to some of my colleagues is that if your result is coming 2 weeks after the sample was collected, and is testing positive, there's no point if that patient has no symptoms for us to say we are going to admit that patient. What we do is to repeat the test. It's possible that the patient or the individual will have tested, will test negative. You understand what I'm saying? But contact tracing is important so that whoever had come in contact with that patient in the last 2 weeks will be properly followed up. Thank you.
There are more questions there. Please, who is taking the microphone around?
Sure. Thank you very much, Dr. Bowale, for your very enlightening and insightful lecture. I'm aware that we actually had a cesarean section done in one of the isolation centers, and I think that was quite commendable. But are we also making provisions to expand the scope of that theater for other possible emergency cases who may turn out to be, COVID positive, emergency or urgent cases, even in other specialties apart from the obstetrics and gynecology, so that surgeries can be done within the isolation centers, and that we don't have to have some mixing within the other general hospitals. Thank you.
Can we have the better?
Thank you, Dr. Omonolu. The plan of HSC really is to get as many doctors as possible trained so that they can be co-opted into the work, even in their own facility. And that's why a lot of us have actually been trained. As for having a dedicated space for COVID-19, well, I may say that for their surgery, that may not be necessary. Because if you take our standard precaution, the likelihood of getting infected is actually is reduced. And this patient will have their surgery in our hospital, as long as we are appropriately dressed, and then that theater can be decontaminated afterwards and can be used an hour after. So having specialized centers where if you have a stability hernia you have to go to, I don't think that will work. I mean, considering the population of the state, considering how staggered the hospitals are, and then distancing between one place and the other, we will plug up that particular hospital if we are to do that. So everybody should be involved. Once we are trained and we do the appropriate thing, I'm sure we'll be fine.
I think there are some questions here. Okay. There's some more questions.
Now, Dr. Bowale, thank you so much for the presentation. Maybe just taking a cue from one of the questions that you answered. Now, we have been instances where, as you already said, the results will not be available for like 2 weeks and even more. What now comes out positive, and we now need to now do a repeat of the test. So that now begs the issue: does asymptomatic patients need any treatment at all? Because during that period, the person was probably positive. It didn't know it was positive, so it's been awaited. The result eventually comes out positive. We now do another one, maybe 5 days after, that comes out negative, and it's as healthy as ever. Because one, after experience, the number of my staff are positive. 2 of them actually didn't even go for isolation. They stayed in their houses. They are as healthy as ever. So that begs the issue: does asymptomatic patients they need treatment at all? That's active treatment. That's number one. Now, so far, we know about comorbidities, hypertension, diabetes. How about chest infections like TB? Has it affected the outcome and in our own environment? Yeah, we used to remove figures, they don't know TB. In our own environment, if we have anything to suggest that they may affect or they may be prone to COVID. Then, number 3, now, the patient presents with dyspnea or other respiratory symptoms or challenges. And because we can't get the patient out fast enough, and start the regular treatment, whatever it is. And the patient now gets well within a regular time, a day or two.
I think
we'll
change the style.
Say or feel that that patient is not COVID positive, or at the very least, patient is asymptomatic COVID. Thank you very much.
Sorry, please can you all write your questions so that we can, otherwise we won't be able to take everybody's questions this way. So please write the questions, we'll read them out to Dr. Bowale. It will make it faster. Excuse me. Microphone. Bring the microphone. Yeah.
Thank you so much, Dr. Adebute. One of the research questions that we are going to find out is whether asymptomatic patients actually benefit from medication or not. And that study is going to start pretty soon. But we all know that even somebody that is asymptomatic today can progress to mild, to moderate, and to severe within a few days. So how do you determine an asymptomatic patient that will remain asymptomatic? Might be a very difficult thing for us to actually say. So with that study, when the result of that study is out, we'll be able to determine whether we'll be wasting our medication, giving everybody Ritonavir, or we'll be doing appropriately. And then for result, as I've said, unfortunately, the lab is trying to clear the backlog, and I'm sure as soon as that is done, result will come out faster than it is. But the advice is that once you are in contact of a COVID patient, a confirmed COVID patient, you self-isolate for 14 days. And that is something that we should still continue to do. So in self-isolation now, and then you send your sample for result. If you don't have symptoms throughout, all well and good. In 14 days you are out. You are less infectious, compared to when you first had contact with the patient. If your result comes out positive, and then if your result comes out negative, it's all well and good. You've not infected other patients. And then for those with symptoms, and you start them on medication, usually, as Dr. Johnson said earlier on, once you treat the common things and the symptoms are still persisting, most likely that patient has COVID. For TB patients, we've not seen any that, in our database now, maybe they had it, they didn't do tests. You understand what I'm saying? But in our database, we've not seen any TB associated with COVID for now.
I'm going to read out a few more questions. I may also add that I know from Luth, they've been looking at their HIV, a few patients with HIV, they have not seen an increased morbidity yet with them as well, if they are being managed properly.
So more questions, Dr. Bowale, you're going to be here for a long time. It's like,
and clearly nobody's going to go for tea break.
This question, I'll just ask like 3 questions. What differentiates contact with exposure in our healthcare workers, and how do you handle these different conditions? Is there a protocol for treating pregnant women? And then how soon after admission or treatment do patients get retested to check whether they are negative?
At the beginning of the outbreak, when we had very small number of cases, we were doing testing every 48 hours. The guidelines is every 2 to 4 days. So we are doing it every 48 hours, every 2 days. But with so many patients on our hands now, and then haven't seen that the mortality in terms of percentage, overall percentage is very low. And then with limited, yes, as I've said, with so many cases and so many samples to process, we've reduced the frequency at which we run repeat tests. So if you are admitted today now, based on the positive result, we'll do a repeat test for you in about 8 to 10 days. Because what we discovered is that doing those repeat tests every 48 hours, a lot of people will remain positive. So what is the point of wasting reagents, wasting manpower when you know that the result is going to be, it's going to be positive? So we wait for about 8 to 10 days when we know that the likelihood of having converted is there, then we repeat the test. And if it's negative, we discharge you. Usually before, discharge is done after 2 negative results. But now we discharge with 1 single negative result. And then you come back for follow-up. And during the follow-up clinic, we also run some tests, just to be sure that this patient has not become positive again. For pregnant women, yes, there's a protocol for handling them, and there are specific hospitals that have been dedicated to handling pregnant women, and that is GIMS and Lagada General Hospital. Difference between contact with exposure in our health facilities. Well, once you are exposed to a positive case, yes, without appropriate PPE, that is without a mask or a respirator where it is applicable, then the chances of becoming positive is actually very high. So these are the category of staff that we see at self-isolate for 14 days. We take their sample, we wait for results, and then if you have symptoms, you can admit them and start them on medication. If you don't have symptoms, we repeat the test after 14 days, and if they are negative, we go back to work. Thank you.
You have like 11 questions. I will be handing them over as I read them. From your experience using Lopinavir, will you say this drug really works? Do you have a control arm to affirm this? That's one. Any post-mortem done on any of your patients? What about asthma as a comorbidity? Can you educate us on what tips a COVID-19 patient who doesn't have comorbidities to mortality? Then any reason, I think I can answer that, for playing down on the symptoms of loss of sense of smell and taste, when this could be early symptoms? I think that I can answer because he gave us the numbers as they saw them. So the patients who came with sense of taste and smell were recorded. That was what he gave us. So it's not being played down. It's just being counted. On convalescent plasma, I believe it's a great opportunity to write our own story and contribute to whatever is known on COVID globally. What are the criteria for giving convalescent plasma, and what is their recovery like and the outcomes generally? And what do you give asymptomatic patients? Thank you. Yes. After this, there'll be one more set of questions and then we will round up.
On the issue of post-mortem, basically we've not been able to get the pathologist to do post-mortem for COVID positive cases. Rather, what we have, understanding we have, even for a patient that has died from any other cause or causes, if you ask them for post-mortem, they will ask us to do COVID test first to ensure that that patient does not have COVID. And that will do for them, and if it's COVID negative, they will do the autopsy, but if it's COVID positive, they don't touch that body. Asthma is one of the comorbidities that are listed as associated with deaths in COVID-19 patients. So asthma is actually very important. Whether Lopinavir, Ritonavir works, scientifically, it's also one of the questions that we've been asking ourselves, and it's going to be one of the research team that will be about to start. Some patients are going to be on placebo, some are going to be on Lopinavir, Ritonavir, and then we will see and compare scientifically. But empirically, if I have to speak based on my own experience, I would say that this drug actually works for those kids, moderate to severe cases. For those who are critical and need ICU admission. I'm not sure the drug is of any help to them. But for those with moderate to severe, I've seen quite a number of patients who came in with SpO2, once the SpO2 of about 89, 90, and we commence them on oxygen, we start them on this drug immediately, and in 72 hours, you get dramatic responses from them. So for me, I would say the drug works, but we need to have science to actually prove that that assertion is true. What if COVID patients who don't have comorbidities into mortality? We've seen quite a number of patients who came in with what looks like a pneumonia. You know, they come with pneumonia, fast breathing, having breathlessness. The SpO2 is usually less than 90, you know, and then chest X-ray will show us that they have quite a number of opacities. These are the ones that eventually we end up losing. And we also observe that quite a number of them are non-Nigerians. You know, they are from a particular ethnic group, and the rate of death in them is actually higher than that of Nigerians. On the use of convalescent plasma, we don't use convalescent plasma for everybody. We actually use it for a specific group, and those are patients who have very severe form of the disease. Data is being compiled as to the recovery rate, as to whether it's actually working, and as to whether it improves the outcome of the patient. As soon as that is, the study is completed, we'll publish, and then everybody will have that. For the asymptomatic patients, what we do is to actually give them the same medication that we give to those with mild to moderate infections. But lately, because of scarcity of bed space, and because we have a lot of patients coming with moderate to severe form of the disease, if you are asymptomatic and you come to us now, what we do is that we give you your medication, ask you to go to self-isolate, and then we will leave you in about a week. And we do that regularly for quite a number of patients with good outcome. So we call that self-isolation. You still have to go and take your medication. Thank you.
Okay, we're on to our last maybe 4 questions, and then we will round on 14. What is the role of telemedicine for asymptomatic patients? Rapid test kits, is there a plan to introduce this in certain centers so as to help clear some of the backlog with the labs? From the possible day of exposure, when do you test to get the best yield? Dr. Bowale, thank you for the great work you are doing. In situations where a patient presents with a febrile illness in pregnancy and is suspected to have COVID, and test taken does not yield results in 2 weeks, patient improves on treatment given subsequently, how long do we keep this patient before discharge so as not to release a possible COVID case to the community?
I'm going to start with the last question. Usually, the belief is that results should come in quite early, but if it doesn't, and we have a patient who has all the symptoms, a probable case, let me put it that way, a probable case, who has all the symptoms suggestive of COVID, we also commend them on medication while we await the results. And we've seen dramatic responses to quite a number of these patients, and eventually, for most of them, we actually write that it's COVID that they have by the time we have the results. For now, we don't keep any patient more than 2 weeks. Once you spend 2 weeks with us on medication, we discharge you to the community, then we'll ask you to self-isolate for another 2 weeks, just to be sure that you shed all the virus in the system, and then you come back for follow-up, and then for repeat testing. Telemedicine is quite useful, and we've used it for a lot of our patients in consultation with specialists, people with some other comorbidities that we can manage. We call the specialists, and then we review patients together on either Zoom or WhatsApp meeting. And I know that some hospitals also have telemedicine conference for their OPD. Patients are asked to call in at a particular period, and they are consulted, and appropriate medication or treatment is given to them. So telemedicine is quite useful. Rapid test kit. I am aware that a company has submitted their rapid test kit for validation to the Lagos Biobank. So validation is ongoing, and as soon as the kit is approved, I'm sure it will be available for so many of us to use. I'm also aware that some private hospitals are using this so-called antigen test, antigen antibody test, but they are not validated, so we really do not rely on them. So as soon as this one is validated, I'm sure we will have access to it, and then that will improve our decision-making time, and then reduce possible loss of patients. Yes, when is the best time to actually get a yield from a patient that is exposed to COVID? We know that the incubation period is between 5 to 14 days. So it's actually better to do it maybe on the 7th, and then repeat it on the 14th or the 15th, so that for a patient that is not exhibiting any symptom in the earlier days, at least by the 14th, he or she should exhibit some symptoms, and then the viremia should also be high, and then you can get a good yield. So the 7th, the 14th is what we practice. Thank you.
Dr. Bowale, thank you very, very much for that beautiful presentation and for all the answers. And just to share with the House, I just want to reiterate something that Dr. Bowale said. COVID is here to stay. I do not see how any of us will not treat a COVID patient. We cannot turn them away, because probably at the rate it is spreading, 1 in 4 of your patients will have COVID. So we all have to be prepared. And I think what is important is to know how to be safe. I mean, I don't mean that it is just a flu, but it is how flu is spread. So the complications are a lot, but you cannot be exposed if we treat every patient as though they're COVID. In other words, mask up and don't see patients without masks. Keep your distance. And if you have to see them, do it as quickly as possible and do your hand hygiene. So as Dr. Bowale said, if the virus cannot get into your respiratory tract, it cannot give you COVID. So that's really what it is. Protect your respiratory tract from infection. But that we will not, otherwise as medical professionals, we will stop practicing medicine. COVID is not going anywhere. So we're going to have to live with it. So I want to thank, there's a question that wants to, sorry, Dr. Bowale, somebody has pleaded for to ask a question. I don't understand the question because it's not written out. So he's going to ask by himself. And then we will all go for tea. And I want to thank all our audiences for being a part of this. Dr. Bowale will answer one more question and then we go. Please keep it very quick.
Dr. Bowale, thank you very much for your presentation. I just wanted to clarify the answer you gave to all the questions. You said that if the patients, that you don't keep patients for more than 2 weeks. You treat for 2 weeks and then you self-isolate for 2 weeks on their medications. Now, is that for patients that test negative after 2 weeks or test positive?
Do you clarify that?
If they're getting the
Usually for a patient who we admitted into the hospital based on a positive COVID test, who is no longer showing any symptoms, though the test is still positive, but no more symptoms, and they've been on medication for 2 weeks, we discharge them to continue on their medication and then do self-isolation. And then we see them back in clinic after the 2 weeks, and then we continue monitoring their lifestyle.